Hello, everyone. Assalamu alaikum. How are you, everyone? How are you, all my dear friends preparing for the exam? Assalamu alaikum, Dr. Noha and Dr. Roa. How are you doing with the revision of the labor complication? Assalamu alaikum. How are you, Dr. Faiza? How are you, Dr. Bushra? I'm fine. How are you, Dr. Ghalia? Yes, again, very busy day. Okay, and I think that yours as well. Okay, guys, so please tell me. How are you doing? How's your exam preparation? Yes, it should be. Yes, I know that you should be very busy with the study nowadays. I know. Okay, so today this will be our revision. It's a second revision, I think, for the labor problems, right? Want to practice some of the most important exam questions. Okay, I know that you are very tense, my dear. Okay, but now it is the time to go back to the basics. Okay, so this is the time when we go for the basic things, like what? Like I tell you, if we have in the obstetric, okay, paper 1 and paper 2, what you will find? You will find in the paper 1 either 50 question of the MRCOG of the obstetric, right? And 50 single best answer of the gynecology, or vice versa, right? In paper 2, you will find the other half of the obstetric. The obstetric scenario tend to be long in the exam, right? And is expected that management of labor is easy for you, or at least you master the management of labor, right? It makes sense because you are a obstetrician, you are now at the level of a registrar. This is your daily activity. This is what you do in the hospital. So they expect from you that you are well and you can manage the cases, right? Right. Okay. In the obstetric scenario, what do we expect to have? In the obstetric scenario, we expect to have antenatal care. From the antenatal care, what you need to cover. Remember the important point or the important guidelines of the antenatal care, starting from principles, the easy principles of the antenatal care. You can revise them in like 30 minutes. Then you go to the problems that can arise during the antenatal care. Like what? Like VTE, very common, right? And now it's now equal to the cardiac disease, for example, in pregnancy as a cause of death. So it's very important. They will ask you in the exam about the VTE prophylaxis and acute management. Something like small for gestational age, you need to cover it, right? It's, focus on the algorithm. Algorithm, I think, is enough. For the VTE, revise our, our file, our condensed file, and the VTE acute management of algorithm of the pulmonary embolism. This is very common. Yes, I know all the questions in this guideline is already highlighted and it came before. So you just, revise quickly those guidelines. From the antenatal care, the problem of the anti-D, for example, or the RBCs. It sounds to be big, complicated, but finally it's like 2 to 3 papers to revise, right? Revise the algorithm, revise the table of the anti-D, and clear it, right? Twin pregnancy, it's a lovely topic, very easy, right? And the twin complication is very common in the exam, okay, including even management of the antenatal management and the intrapartum management of the twin. So easy, inshallah. Now you come to the maternal medicine. I'll tell you something, okay? For the maternal medicine, remember, diabetes, hypertension, those are the big names. Then go to the thalassemia and sickle cell. Why? Because they are recently, tested in the exam. There was a recent article. Okay, so revise them quickly. Okay, from the inherited bleeding disorders, just revise what to do if a woman had a procedure, okay, before the procedure, how to optimize the levels, okay, revise the inheritance of the disease, have some question, single best answer question on the ultrasound finding, so things will become easy. Cardiac disease, stick to the cardiac quiz. The cardiac disease quizzes is very easy, okay, so just stick to this quiz and everything should be fine. Then again, you will have some minor questions that repeated in your exam, okay, for other topics. Shall I study the whole topic? No. Study a smart summary of the topic, either it's a table or algorithm, or even from the recall the question, highlighted information, and finish maternal medicine. Don't stay there for long, okay? Maternal medicine is very big, okay? And this is now the time to secure the big names, the big topics, okay? Then again, you will come to the labor management. If you come to the labor management, intrapartum care guideline from the NICE is very important. The fetal monitoring CTG is very important. Assisted vaginal delivery, the GTG is very important. Breech delivery is very, very important. Okay, complication of labor like the problems of perineal tear, it comes, frequently in the exam. Postpartum hemorrhage, no doctor without good management of postpartum hemorrhage. This is a very daily cases that we see in our practice, right? Then we will have cases like sepsis or small, it's small guidelines. Revise them quickly, okay? And now you've finished with the obstetric, okay? So you will tell me, doctor, how about update here, took articles there? No, please, now it is a time to clear concept and stick to the basics, okay? And solve as much as you can from the MRCOG questions, a complete scenario or a single best answer scenarios even, but it should be a complete scenarios only, okay? Why? Because you should learn how to solve the questions in the exam by a training on the similar questions, right? I know some people now have this strategy that is the curriculum is too big, it's too large for me, okay, and I want to just get, pick whatever I want to pick, okay, from the topics in the recalls, for example. So I'll spend my time, okay, fleeting between the Telegram groups or the Facebook groups and so on. Is that a good strategy? This is a strategy to fail, 100%. Okay, this is a strategy to fail. Some people, they are, very lucky, okay? And they studied a lot and they passed this exam after 4 or 5 attempts. They are present in all the groups, okay? Since maybe 2019 or the time of the COVID 2020 till today, okay, you will find them. In every free meeting, you find them. In every free group, you find them, okay? And then after that, at one attempt, they get lucky and pass, okay? You don't want to be one of them, right? Success is simply, okay, is a summative of, result of the effort that you do every day. So please clear the guidelines, whatever, your previous level of study or what you have done before. Now it is a time to focus on the big names, okay? So from the big names, of course, I didn't tell you all the big names of the obstetric because I would forget some. But if epilepsy, for example, okay, please don't forget this one and the common question of the epilepsy. We come to something like the perinatal mental health. It's commonly asked in the exam, no exam without it, okay? So big names, clear those big topics, the main topics, and then solve the questions, complete questions, either from books, either from websites, okay? But just complete scenarios, okay? Have your time from now till the exam for daily testing. You should have a time-bound test, okay? like 1 hour, 2 hours, you're testing yourself. Okay, 3 hours, 5 hours, up to 6 hours, because the exam is 6 hours. How are you going to manage the time and the stress, okay, and the mental exhaustion at the day of the exam without training? You'll never do that, right? So you must be on that time, okay? You must, my friend, test yourself before the real exam, okay? One example of testing yourself is one paper like this. You can test yourself by solving this paper, and then after that, you find how much did you get? Is it 90%? Is it 80%? Is it 85%? And then you can just look to what questions that you did wrong, okay? And you know that this is your weakness point, revise them or go to the reference you study from, okay? And everything should be fine after that, right? Yes, Dr. Noha, I do really recommend that you do a 200 question per day, right? So as much as you can. I know that this is your best chance, guys. You booked this exam. It's almost like 1 week for the exam, 1 week and a day. Please, okay, make the best of this week. Okay, so daily testing. Okay, guys, I don't want to waste your time. So let's solve this mock paper, okay? And inshallah, it will be an easy one. So for the question number 1, a gravida 2 para 1, previous normal vaginal delivery, now in spontaneous labor. There is normal progress to cervical dilatation to 7 cm, then 6 hours to full dilatation. Contractions are now 2 in 10. No fetal head is palpable per abdomen, and the head is the spine and in the direct occipital posterior position. CTG is normal. So what you will suggest here? Okay, so currently, okay, I can say that this is, okay, inadequate contractions, 2 in 10. So if the contractions are not adequate, okay, I need to solve this first, okay? Shall I start operative vaginal delivery with this contraction, 2 in 10? It doesn't matter, Dr. Noha, it is insufficient contractions, okay? So this is your key word here. This is what make you solve the case, right? The 2 in 10. So 2 in 10 needs endosomal, easy, right? Shall I proceed directly to cesarean section? Why? I don't have any, indication to go for cesarean section in this case. Yes, and most of you answered correctly. Well done. Let's see the next one. A primate with a history of idiopathic thrombocytopenic purpura has been in the active stage of labor for 2 hours and actively pushing for 1 hour. No pull is palpable per abdomen. The vertex is +2 station, right occipital anterior, and no caput, no molding. What you will suggest here for this primate? She had idiopathic thrombocytopenic purpura. There is a risk of bleeding to the fetus or to the mother mainly. Okay. So can I apply here operative vaginal delivery? Yes. Okay. So if I'm afraid of the bleeding, let's say you are afraid of the bleeding. He didn't say anything about the level of the platelets here, okay? So if I'm afraid of the bleeding, do you think cesarean section carry higher risk of the bleeding or the vaginal delivery, the operative vaginal delivery? Which one? Cesarean section carry more risk. Okay. Okay, so shall I do this trial in the theater or shall I do it in the room? This is the second question. Okay, so you remember in that algorithm, okay, of the guideline of the assisted vaginal delivery? It's not very high risk, Dr. Noha. Okay, so what do you remember, my friends? You remember that if it is low station, right, and the rotation is 45 or less, right, where shall you deliver her? Room. Okay? Okay, so I will go for B. Okay, my friends? Why? Because it's right occipital anterior. Again, this is not a transverse. So if this is, let's say this is the pelvis and this is the fetal head and the occiput is here. Let's draw our levels. So what do you think? Mostly this is a 45 or less, okay? So yes. No, I'm not worried. Okay. Yes, answer is B. Abrimi has been in the second stage of labor for 3 hours and has been pushing for 2 hours. The head is 1/5 palpable. Okay, so Dr. Vic, I assume that, you know, the recommendation in the guideline when we use to go for the instrument that most likely, okay, to be successful. Why? To avoid the sequential use. Okay, so I have 2 choices between forceps and kiwi, vacuum. Which one have a higher success rate? The forceps, so I go for it. Okay. Abrimi has been in the second stage of labor for 3 hours and has been pushing for 2 hours. The head is 1/5 palpable. Vaginal finding is vertex at +1. Station, right occipital to posterior was caput plus molding plus CTG is reassuring. So what you will suggest for this case? Okay, so if it is 1+, this is a mid-cavitary, right? So a mid-cavitary, do I need rotation or I don't need rotation? It's right occipital posterior. Okay, so what is the instrument of choice for this delivery? Okay, sorry. This should be a rotational delivery, right? So I will go for Keelan, not the nivel part, right? Okay, so shall I choose B or E? Of course, this is E in this case. A trial in theater, okay, plus or minus cesarean section, right? Because nivel parts is not a good answer for a right occipital posterior. I need rotation, I need the Keeland. Good. So gravida 2, para 1, previous normal vaginal, has gestational diabetes, and she's on insulin now. She was induced 38 weeks of gestation. A baby is large. Second stage has lasted 2.5 hours, and she has been pushing since she was fully dilated. The CTG showed deep early deceleration. 2/5 pull of the palpable of that are palpable per abdomen, so 2/5. Vaginal finding, vertex at +1 station, left occipitotransverse, slightly deflexed, caput 2+. Can I go for assisted vaginal delivery in this case with the 2/5 palpable and this finding? No, right? So I will proceed for cesarean section, right? So answer is C for cesarean section. Which of the following conditions can permit the use of either forceps or ventouse and not forceps exclusively? After coming ahead, can I use ventouse for it? No. Face presentation? No. Occipito-posterior? What do you think? Yes. Prematurity? Gestational less than 32? No ventouse in this case, no vacuum. Suspected coagulopathy? No vacuum. So it's only occipito-posterior position, okay? And you all know that a vacuum, especially the Kiwi one, can have, can help you with the rotation. But again, it's depend on the success rate. Your choice in the exam depend on the suitability for the case. And then if you have the choice between both of them, then it will be which one is having the higher success rate. During the postnatal debrief, which of the following are not based on evidence? Yes, when you let the midwife do the debriefing, okay, who is responsible to do the debrief after delivery? Yes, usually doctors who are involved, even sometimes if the event is a large event like death, for example, that must have a consultant, some senior obstetrician with experience. A woman has delayed second stage of labor and she is tiring. So you discuss the options for further management with her, and she consents to an assisted vaginal delivery. In which clinical situation would ventouse delivery be contraindicated? Yes, in the previous question is A, my dear. Yes, it's the contraindication of prematurity when the gestational age is less than 32. Well done. You are the labor ward specialty trainee called to assess a multiparous woman in labor at 42 weeks of gestation. Fetal membrane ruptured prior to the onset of contraction 12 hours ago. Full dilatation was diagnosed 2 hours ago, and there has been no descent of the fetal head despite of 1.5 hours of active pushing. The MRCOG has been given for analgesia 3 hours ago. Your examination revealed that the fetus encephalic presentation was 2/5 of the head palpable per abdomen. You confirm full dilatation. Fetus in the direct occipito-posterior position with a caput of 2+ and molding 1+. Presenting part is at station -1. The fetal CTG is reassuring. What is the most appropriate management given of the above option? What is the condition? What do you think this condition is, my friend? This is CPD, yes. So it's a cephalopelvic disproportion, go directly to cesarean section. Well done. A healthy primey, pregnant with dichorionic diamniotic twin with normal gross and no antenatal complication. She present in spontaneous labor at 36 plus 5 weeks of gestation. An ultrasound scan confirmed twin 1 to be cephalic and twin 2 to be transverse. She chose to have vaginal delivery and twin 1 delivered with no complications. Syntocinon is commenced and twin 2 is stabilized in the breech position with reassuring CTG, but after 10 minutes it's not descending. What is the recommended delivery interval in vaginal twin delivery? Yes, it's B. Everybody agree for B. Okay, 30 minutes. So a 26-year-old primey at 36 weeks of gestation with dichorionic diamniotic twin has a twin 1 in cephalic position and twin 2 in breech. The pregnancy has been uncomplicated and both twin are on the 50th centile of gross. CTG has been normal throughout labor. Twin 1 is delivered uneventably, okay, following which twin 2 become transverse. Contractions diminish and it has now been 45 minutes since delivery of the twin 1. What is the optimal management in this scenario? Can I give syntocinon, for example? No, it will cause a uterine rupture with the transverse. So, yes, internal bodalic version and breech extraction. Yes, answer is C. Well done. Question 11. We have a 26-year-old gravida 2 para 1 at 33 weeks of gestation with monochorionic diamniotic twin, present with twin 1 in cephalic position, twin 2 in breech position. The pregnancy has been uncomplicated to date and both twins are above the 50 centile for gross with no significant size difference. CTG has been normal throughout labor. Twin 1 is delivered uneventably and twin 2 is breech but high up. Contractions are adequate, but 30 minutes have passed and CTG is now suspicious. What is the optimal management in this scenario? Okay, so if we have a delay of the delivery of the twin, what shall we do? If the CTG is pathological, okay, and you think that delivery is not imminent, you can go for cesarean section. But if the time passed, the CTG is just suspicious, what you can do in this case? Can you try for the breech extraction or go directly for the cesarean section? Yes, you go for the breech extraction, it's faster. Yes. What is the most appropriate management option in the following situation? A woman is sent to the labor ward by her GP with raised blood pressure. On admission, the blood pressure is 180 over 100. Please select. If the woman admitted in the labor ward with severe hypertension, but her general condition, okay, she can take oral. What you can give her? We start initially with the oral one, right? This EMQ similar EMQ to this came in the exam before, okay? Please don't commence IV first if the case can take oral, okay? In the nice hypertension, right? Oral is there, right? So start with oral. What is the problem in that? Okay? Does the patient have fits or something? Yes, even if severe, try oral, and then please have a look to the NICE guideline. Okay, it's written there how to manage the severe hypertension. Okay, you start with oral, and then if the patient cannot tolerate oral, go for, or it's not effective in the first instant, okay, you go for the IV. Then after that, because the IV, by the way, guys, it's not without side effects, okay? So then after that, you can go to the next line of the medication. So let's see the next question. The woman blood pressure does not settle after next hour, and she start to complain of headache. Her blood pressure rises to 180 over 115. Please select. So now, which drug you will try? Here I will go for the IV labetalol, okay? So the indication, we have to go stepwise approach, right? You go for the IV labetalol, right? If symptomatic of what, my dear? Look, my friends, what is the role of antihypertensive? What is the role of the magnesium sulfate? Magnesium sulfate is given to prevent the eclampsia, right? Is a magnesium sulfate treatment of severe hypertension? No. Can I give both medication to the same woman? Of course, yes. Right? So here we speak about a medication to lower the blood pressure, since the blood pressure appears to be raising, right? So I need to give something to control her blood pressure, right? There is no conflict in that. If I have a patient with impending eclampsia or red flag signs or symptoms of eclampsia, even if her blood pressure is not severe, this is an indication of magnesium sulfate, which is a separate indication. Okay, but since he highlighted in the question the high blood pressure as the main thing, okay, so treat the high blood pressure now. It's so severe and it's raising, right? If he told you that the patient had flickering of lights, the patient had epigastric pain, the tendon reflexes are exaggerated, magnesium sulfate. So he wants you to choose magnesium sulfate, so he guided you to choose the magnesium sulfate. He wants you to choose the antihypertensive, then you choose the antihypertensive, okay? Anybody, my dear Dr. Maya, okay? Anybody, my dear, okay, will have headache with the blood pressure. It's not wise actually to leave the blood pressure and then go to the best option, okay, to be the magnesium sulfate. Shall you give magnesium sulfate and wait? It's the art, my dear. It's art in how to choose the best answer. Okay, I'm not saying magnesium sulfate is wrong. Don't give magnesium sulfate in this case, but I speak about the question. How did they design the question for you to choose the best answer, guided by the buzzwords in the question? They give you key and you choose based on this key. Okay? Okay, so I will be happy actually to share with you. One second, I'll just open the presentation. Okay, my friends, so this is a nice summary of the hypertension, okay, in pregnancy. I'll just go to the management of severe hypertension. So my dear here, please have a look to the management of the hypertension in severe hypertension, severe preeclampsia, and the eclampsia. Okay, so this is even in the critical care. Okay, so you need to measure the blood pressure hourly in women with hypertension and every 15 to 30 minutes until the blood pressure is less than 160 over 100 for the woman with severe hypertension. Treat women admitted to critical care during pregnancy or after birth. So this is even for the critical care woman, not only the woman who admitted to the ward. Labetalol, oral or intravenous. Okay. Then next option is oral nifedipine. Third option is intravenous hydralazine. Okay, my friend. So this is how we go in the sequence, because we learned that we will do the first option as per the guideline first, right? Okay. So continue appropriate ongoing antihypertensive treatment after initial management, right? Monitor response to the treatment and ensure that the blood pressure falls. Identify adverse effects for woman and fetus. Modify treatment according to response. If the blood pressure controlled within the target range, don't routinely limit duration of the second stage of labor. And if the blood pressure does not respond to initial treatment, consider operative or assisted birth. Rule of magnesium sulfate. Give intravenous magnesium sulfate if woman with severe hypertension or severe preeclampsia has or recently had an eclamptic fit. Okay, this is one thing. This is the first indication. Preeclampsia, not only hypertension, and I hope that we understand difference between both. Okay, and what severe hypertension or severe preeclampsia who had fit or recently had fit, or consider giving intravenous magnesium sulfate if birth is planned within 24 hours in woman with severe preeclampsia. Again, okay? So this is another indication. You can consider giving the intravenous magnesium sulfate if the woman has severe preeclampsia if you're planning delivery within 24 hours. Don't use the diazepam, phenytoin, or anticonvulsant as alternative to magnesium sulfate, even with women for the eclampsia. Okay. So this is, my friends, for the management of severe hypertension. So please note that antihypertensive comes first. Okay, unless you have fits or you have imminent eclampsia, so you want to prevent fit, right? Along with antihypertensive, okay, not alone. Fluid balance and volume expansion. The fluid balance comes also in your exam. Remember, in severe preeclampsia, you need to balance between the pulmonary hypertension and the kidney injury, right? So don't overload the woman, right? Otherwise, you will cause a pulmonary edema, for her. So limit maintenance for fluids to 80 ml per hour. Before that, we used to find it in some resources as 85. So it's fine. If you solve a question or something and you find 85, it's still okay. But in the guideline recently, it was written as 80. Unless there is other ongoing fluid, for example, fluid loss, for example, hemorrhage. So only in the case of hemorrhage, I can increase the rate. Don't preload with intravenous fluid before establishing low dose epidural in the woman with severe hypertension. Don't use volume expansion unless hydralazine is antenatal antihypertensive. Then in this case, if you want to add hydralazine, so consider using 50 or less, 500 or less of crystalloid fluid before or at the same time as first dose of hydralazine in antenatal period. Why? That's because the hydralazine can cause hypotension. Yes, my dear, we start with oral. So it was a surprise, right? Okay. Dear friends, you are welcome. Dear friends, so now moving to another patient with hypertension or what? No, not hypertension now. It's primary known case, yes, again hypertension. Primary known case of hypertension during pregnancy, had an emergency cesarean section due to non-progress of labor and fetal distress. On return from theater, after 2 hours of monitoring, the woman has passed only 30 ml of urine. Is that enough? No, right? This is oliguria, right? Okay, so what can I do now for this patient? Can I still offer her fluid therapy? Antihypertensive, magnesium sulfate, or what? What do you think you need to give her? When you have a woman had emergency cesarean section and now she had oliguria, okay? Now you want to know what is the reason of this oliguria, okay? Are you suspecting kidney injury or it's because of the hemorrhage, hypovolemia, right? So which one of the options can give you the answer? What we do is we do what is called a fluid challenge, okay, my friend? So you give her some of the fluid and see if there is improvement or not, right? So what type of fluids shall be given in this case when you suspect a hypovolemia and oliguria? In the cases of preeclampsia, okay, you are afraid, okay, if you give 500 ml of crystalloid, that this is well accumulate, you know, the extracellular spaces, and it will go for the edema, pulmonary edema, right? So which fluid has large particle and cannot escape from the blood vessels, and it will maintain intravascular, so it will maintain, you know, the volume. It's a colloid, okay? So we consider fluid challenge by 500 ml colloid over 30 minutes, okay? We learn this information, right, from the strategy, okay, before. Okay, my friend, even this was a question that was there in the old website. You will consider fluid challenge 500 ml colloid over 30 minutes, my dear. Okay, I can restrict the fluid intake to 85 ml if I have euvolemia. Means that everything is okay, urine output is okay, no bleeding, nothing. But hemorrhage, suspected hemorrhage, need to be tested first. Okay. A 25-year-old lady, 3 hours post-delivery following an emergency cesarean section at 34 weeks of gestation for severe preeclampsia. She remained on the infusion of IV labetalol and magnesium sulfate 1 gram per hour, which were both commenced prior to delivery. Okay, and her midwife is concerned that she is becoming increasingly lethargic. She checked her observation and asked for a doctor to attend. Okay, So her observation as follows: blood pressure 125/72, respiratory rate 10, pulse is 85, oxygen saturation 93, and urine output 10 ml in catheter since delivery, means since 3 hours. So the patient received magnesium sulfate in addition to the labetalol post-surgery, right? Now she is 3 hours and she only passed 10 ml. Her respiratory rate is only 10, okay, in minute. Even her oxygen saturation is 93. So what is this? You suspect magnesium sulfate toxicity, especially that she is lethargic. So what is the antidote? Antidote is very famous. So you will give calcium gluconate, right? And remember the number 10. 10% calcium gluconate, 10 ml IV over 10 minutes. Clear, my friends? Okay. So another question here about 24-year-old woman present to the emergency department at 4 days postnatal, feeling unwell with generalized malaise, nausea, and headache. She had a normal vaginal delivery of 3.4 baby boy and sustained a small second-degree tear, which was sutured without complication. Her BMI is 42. On arrival, her observation as follows: pulse 100, blood pressure 165 over 115, temperature 36.3, oxygen saturation 97. You arrive at the emergency department, and while receiving handover from the admitting doctor, she had a tonic-clonic seizure that lasted for 1 minute. The emergency department team has already secured intravenous access and sent relevant blood for investigation, but results are not yet available. She is administering oxygen at the moment. What is the most appropriate immediate management option? First, what's your diagnosis? Give 4 gram magnesium sulfate over 5 minutes. Good. A 27-year-old low-risk primate at 38 weeks of gestation has rupture of membrane at 5 cm with thick meconium and uterine contractions at a rate of 3 in 10 minutes. She commenced on continuous fetal heart monitoring, and a plan is made for re-examination in 4 hours when she is found to be 6 cm dilated and has a normal CTG. Syntocinon is commenced following medical review. She is re-examined in the by the registrar 4 hours after the onset of contraction at a rate of 4 in 10. She is found to be 6 cm with 2 plus caput, and CTG is suspicious. What is the most appropriate next step? Yes, it's a cut to cesarean section for the non-progressive labor and suspected CBD. The question 18, 25-year-old, gravida 1 para 0, has uncomplicated pregnancy. She is currently 39 plus 1 and reports a gush of fluid. The previous one is cut 2, not cut 1, my dear. So and report a gush of fluid 5 hours ago. She is now contracting strongly 4 in 10. On examination, fetus in the cephalic presentation with a head 3/5 palpable. Vaginal examination revealed effaced cervix, which is 5 cm dilated. Head is at station -1 to the spine with no caput or molding. The position is not defined and there is a clear liquor draining. Which of the following is the most appropriate method of monitoring the fetus in this stage of labor? Yes, it's intermittent auscultation. In the first stage of labor, it should be 15 minutes. Thank you. Yes, D. In spontaneous labor, a para one in spontaneous labor at 39 + 1 weeks, and she's being monitored by CTG because of raised blood pressure. She had a history of chronic immune thrombocytopenia. She is 4 cm dilated, draining glycol on admission and progress to 8 cm in 4 hours. The CTG show baseline of 145, variability 60, and 50% of contractions for the last 30 minutes. The woman has already had IV fluid and the change in position. You are called to review the CTG. What is the first course of action? How about this CTG? Is it pathological CTG or not? Okay, so what is the action that you can take now? Delivery by cesarean section, is that the first action? Or fetal blood sample? Remember, he wants from you the first action. Okay, no fetal blood sampling. So what shall I do? Can I still do a fetal scalp stimulation? Okay, so what else can I do here as a first action? What do you think is the appropriate one? Yes, okay, so she already had the IV fluids, so I'm not going to offer this. Okay, so why not fetal scalp stimulation? Okay. Okay, yeah, for suspicious now, the old answer was fetal scalp stimulation. Now its rule comes with the suspicious. Yes, okay. Look, my friends, In the old time, we used to have some actions, okay, with the pathological CTG, especially if it is in the first stage of labor, okay, trying to buy some time to check how about the during the examination, see the fetal scalp stimulation. If the fetal scalp stimulation improved, show improvement or acceleration in the heart rate. So this is a good sign. You do fetal blood sampling, then you repeat the fetal blood sampling, and so on. Nowadays, after removal of that, the fetal blood sampling, okay, and with the recommendation of the NICE with the fetal scalp stimulation with a suspicious CTG, okay, they now, okay, prefer to go for expedited delivery, right? Right? So they now go for the expedited delivery, okay? Okay, so I can't really choose the delivery by the cesarean section as the first course of action, right? And no action needed is not. IV is not, okay? So since this question is already old in the question bank, okay, and the most suitable answer is the fetal scalp stimulation, so we will choose for this question the fetal scalp stimulation. Otherwise, okay, this is the, you know, near to truth now, or this is the practical step that will be done during the vaginal examination, as you all know. Okay, so I'm sorry, I can't choose the delivery by cesarean section directly. Okay. Okay, it's not the first course of action. First, I have to exclude the acute event. Assessment of the, I need to do a full assessment of the fetus and the baby, right? Including the examination, exclude acute event, right? And then I will take the decision for the delivery. Right? Yes, it should be the full assessment, to be honest, or exclude acute event. This should be the correct answer. So now, so far we will go for C. Okay. This is the, you know, suitable one of the 5, but otherwise I can't go for any other option. Other options are wrong. Okay. Fetal scalp stimulation can be done during the vaginal examination to exclude the acute event. I'm not saying this is a recommendation. I just say for this question, this is looks like, you know, the best suitable one. Okay, guys. But you should know what is the action in the pathological CTG, right? What is the action in the pathological CTG? According to the fetal monitoring, the new one. What's my problem with the risk factor, guys? What's your problem with the risk factor? Risk factor for what? Yes, but he just asked about the first action that to do. What is the first action to do? So people who are not convinced with the fetal scalp stimulation, are you convinced with the cesarean section, for example? For you, do you think that this is more logic to choose it as a first action? This is what the guidelines say for the CTG trace as pathological. Obtain urgent review, exclude acute event. So this should be the one. Okay. For example, cord prolapse, suspected placental abruption, or suspected uterine rupture that need immediate intervention. Perform a full risk assessment. Include a full set of maternal observation, taking into account the whole clinical picture and document finding. Consider possible underlying causes and undertake conservative management as indicated. If the CTG is still pathological after implementing conservative management, obtain a further urgent review, evaluate the whole clinical picture, and consider expediting birth. Okay, so can you see birth here comes in which line? I can't choose it as the first action, that's why. It comes here after all of these actions done, right? So that's why, guys, I'm against cesarean section as the first course of action. In some other questions, you think that the scenario suggestive of the cesarean section for non-progressive labor or for pathological CTG, he's asking you for appropriate management, or what is your plan of management for the delivery of this case. And he give you options, including vaginal delivery or operative vaginal delivery or cesarean section, and you suggest delivery by cesarean section. So it's another context. Okay. She had the change of position, my friend, and she had IV fluids. Okay, so the lady had already the conservative management done. It should be exclude acute event, vaginal examination to exclude acute event. Okay, so my friends, again, thank you for your time, okay, and for your understanding. We are facing, you know, with the MRCOG all the time, questions have been updated. We are actually chasing the guidelines and update here and there, okay? So the change in the question scenario, okay, does not go with the same rate as the material update. Okay, so sometimes you find a question like this in the exam, so be flexible, choose the most near to true, okay, or the one that is even matching 80% of your. Okay, so in this question number 20, a 32-year-old primie with no antenatal risk factor attended the antenatal clinic for discussion of management of prolonged pregnancy. She is at 40 weeks of gestation and has a membrane sweep in the past 7 days. You have discussed the risk associated with prolonged pregnancy with her. Which is the most appropriate management? Yes, you will advise the induction after she completed 41 weeks, right? Well done. Okay. Yes, dear, I'm just opening another file, okay, to complete some questions of the EMQ, obstetric EMQ today. And it takes few minutes, okay, maybe 1 or 2 minutes. I need to tell you something, guys. You know what? I had a dream yesterday, and I want to tell you about this dream. Inshallah, everything will be fine. Okay. So I'll tell you about my dream. Yeah. It was that I have physics exam. Okay. I was in a building, and in the first floor, I have physics exam. Okay. And I wasn't prepared, and I wasn't ready for the physics exam. Then I said, no, I'm not going to go for this exam. I'm not ready. So I went to the second floor, and second floor was MRCOG Part 2 exam. Same thing, feeling of, oh my God, I'm not ready. I'm not prepared. Okay, so I went to the third floor, and it was part 3 MRCOG. And the same situation was there. So I'm very poor, my friend. Yes, and even the stress of exam. I had this type of questions of these dreams only when I had examination. Guys, you are repeating all of this every batch. Okay, I repeat the same experience again, so it's all coming back to me. And in this time, it was like a combo. It's from the physics exam to part 2, part 3. I think those were the most stressful 3 exams in my life. So I wanted to share this with you, just only, to see how poor I am. And to tell you that I feel the same as yours, guys. I share the same feeling, and emotions like you. Inshallah, you will all pass. Okay, guys, please pass for me. Okay. Inshallah, you will all pass, and we'll celebrate with you. So I will feel the same feeling of happiness, and success with you again. So please let me share the same with you. Inshallah. Good luck, my friends. Believe me, I pray for you, and I want to feel, that I have accomplished my job with you. Okay, and you are all ready for the exam, and you are ready to go. Okay. So, dear friends, let's have some of the questions before we go today. And we have a woman present with a swollen cuff at 39 weeks of gestation. What is the most appropriate treatment? Thank you, my friend. Thank you very much. Thank you for all of this beautiful feeling. I know that this is a true feeling between us, alhamdulillah. So what you will do for this lady? And I have chosen this one specifically because it's an exam question. Yes, well done, my friend. So if the woman comes to you near to delivery, okay? Near to the time of delivery, shall I start on low molecular weight heparin and she comes to me with delivery at any time? Okay, with the bleeding risk, with the low molecular weight? It's unfractionated heparin. Right? Tricky, isn't it? It's not that much tricky. You are very good, and you have answered correctly. It was there in the guideline as a special situation, right? Yes. Well done. In the question 23, 35-year-old woman is admitted to the hospital at 30 weeks of gestation with a blood pressure of 155 over 105. So she's hypertensive again and significant proteinuria. So that's mean even that she had a preeclampsia. Is it a mild to moderate or severe preeclampsia? The lady now had no symptoms. Okay, what is the most appropriate management? Yes, you have choose the oral labetalol. Yes, well done. Okay, so which option is a start or a change to oral labetalol? This is the most suitable option of these. Yes, well done. Okay, so another question about vaccines. Which description below best describes the type of vaccine for the pathogen above? Yes, it's live attenuated. That's why we don't advise it during pregnancy. And even if the woman receives the rubella vaccine, what we will do, we will advise her to have a reliable form of a contraception for at least 1 month, right? Good. How about the varicella vaccine? Varicella vaccine is killed? Are you sure? The varicella zoster vaccine? It's live attenuated. It's called Oka strain. Okay? And it's very effective as well. The Oka, yeah. So nowadays we use the Oka strain. So it's a live attenuated vaccine. It's not killed. Okay, can I give it in pregnancy normally? Is it recommended in pregnancy? No. So even if the woman had exposure to varicella, right, during the pregnancy and she did not catch the infection, she had no immunity, we advise her to have the vaccine after the delivery, right? A woman who developed gestational diabetes in pregnancy attended for a 6 weeks postnatal check and fasting plasma glucose is measured above what threshold type is type 2 diabetes likely and diagnostic testing recommended? Which plasma glucose level is most appropriate? Fasting plasma glucose of 7, of course, millimole per liter or above, that they are likely to have type 2 diabetes. Yes. A woman attended 4 days after delivery with painful swollen cough. She's commented on therapeutic heparin, but a cough Doppler scan the following day show no evidence of thrombosis and the heparin is stopped. She continues to remain symptomatic. For each clinical scenario, what is the most appropriate next investigation? So the lady have swollen cough, right, first. And she was commented on the therapeutic heparin. But Doppler scan, no thrombosis. Heparin stopped, which is normal, you know. So she continued to remain symptomatic. So what shall I do next? So we will perform the ultrasound on which days? Day 3 and 4. Right? Yes, so I repeat the same. Compression duplex ultrasound, right? 3 and 7, yes. A woman who is 5 days postnatal present with a swollen cough and deep venous thrombosis, confirmed on the duplex scan. So this time it was confirmed. Blood is taken for coagulation screen, urea, electrolytes, and liver function test prior to commencement of heparin. So, what you need to do now? Which investigation you need to do now? It's a tricky question. Read it again. Please, please. Yes. So I have seen, yes, some answer that people, yes, they catch the trick. What blood investigation is done? Coagulation screen, urea electrolytes, and liver function. Okay. How about the full blood count? Yes, full blood count is very important because through the full blood count, you will know what is the level of platelets, right? Yes. Sometimes questions come like that in exam. Which maneuver for shoulder dystocia? No, start low molecular weight heparin first, my dear. This algorithm should be now, you know, drawn everywhere, okay? You can draw it everywhere. You have to recall this algorithm, Dr. Abir, for the exam. Low molecular weight heparin comes before the investigation in the cases of pulmonary embolism. For the cases of VTE, suspect VTE, okay, and in the leg, like a DVT, okay, and the algorithm, or sorry, the guideline says that you start low molecular weight heparin on suspicious, right? This is what the guidelines say. In this question, in the 28, the sequence of the events is not in line with the guideline. It's not your job. It's not my job. Okay? We don't question the examiner. Right? Why? Because not every doctor working in a hospital in the UK have MRCOG, right? Mistakes happen or different protocol occur, yes. But your job in the exam, if they ask you what is the next management option or what is the next step in the management of a case of DVT, is to write start on low molecular weight heparin before the duplex scan. Is it clear, Maria? Okay. Because many scenarios like this in the exam, like a question about a woman in labor, they did this and that. Okay, don't question the scenario. Okay, forget it about it. Now you are the one who is being tested. You've been asked one question. Answer the question. That's it. Okay, don't think if they did something wrong or not. And don't take the question as a reference, the scenario and the question as a reference for you. Which maneuver for shoulder dystocia is associated with the highest rate of serious maternal morbidity? Invasive ones, right? Like what? Symphytomy, yes. Yes, symphytomy. So answer is H, yeah. A woman with BMI 32 attended for a 75 oral glucose tolerance test. And she's para 1 and diagnosed with gestational diabetes in her first pregnancy, which was managed with diet alone. Above what 2 hours plasma glucose level would gestational diabetes be diagnosed on this occasion? Which plasma glucose level is the correct one? They ask about the level of the testing of diabetes, what are the level for the control, everything in your exam. Okay, so please revise them in your final revision. To diagnose gestational diabetes, if the woman had either fasting plasma glucose level of 5.6 or 2 hours plasma glucose level of 7.8. right? So for the 2 hours, 7.8. Good. A woman who is 34 weeks of pregnancy present with chest pain and dyspnea. Examination of the cause are unremarkable. Okay, so she had symptoms of pulmonary embolism without DVT, right? What is the most appropriate treatment? Low molecular weight heparin, yes, well done. In 28-year-old with chronic kidney disease who had just had a positive pregnancy test, blood pressure 130/80. Apart from some nausea, she's feeling well. What is the most appropriate management? She should take aspirin and the dose should be 150. However, again, the question is written in the old dose, 75. Still, it is the most correct one. Yes, so she should receive the aspirin. Till what time? From 12 weeks till delivery. Yes, well done. A woman present at 39. It should be everybody now, my dear, 150. Okay, but the old dose is 75 and is still found in the questions. A woman present at 39 weeks of gestation with a swollen right leg. An ultrasound scan confirm a right iliac vein thrombosis. What is the most appropriate treatment for right iliac vein thrombosis? Temporary vena cava filter in the peripartum period for patient with iliac vein VTE. This is to reduce the risk of developing pulmonary embolism. Or for the patient who had recurrent as well, right? So since the patient is again 39, so for the 39, what shall I choose? This is a peripartum, okay? So either near to delivery or after delivery, right? So here I will choose the inferior vena cava filter, my friends. Okay, because of the gestational age. A woman in her first pregnancy present with intensely pruritic erythematous papules that originate in the umbilicus and have now spread to the limbs. After 2 weeks, the lesion developed into vesicles. Which condition fit with this clinical scenario? Guys, the previous question answer is F. Okay? Just to inferior vena cava filter in the previous question. I didn't say anything about the low molecular weight heparin, okay? Focus on that. Question 34, please. Which one, okay, match with the description? Itching in pregnancy, chronic skin condition or itching condition or skin dermatosis, all are important in your exam. Itching in pregnancy in the obstetric and itching in vulva in the gynecology. So it's a pemphigoid gestation. Yes, this is the one that have lesions looks similar to the varicella. A woman with chronic hypertension who took linsopril preconceptionally was switched to methyl dopa. during pregnancy. Now 2 days postnatal and wishes to discharge from the hospital. She's breastfeeding. What is the most appropriate management? So of course, this lady, she will stop the methyl dopa. Now she can go back to the ACE inhibitors. Yes. Okay, so which ACE inhibitor to give? Enalapril. Right. J, yes. Okay, how about hepatitis B vaccine? What type of vaccine is that? It's subunit. Yes, it's subunit vaccine. Well done. A woman at 30 weeks of gestation in otherwise uncomplicated pregnancy present with intense itching. Her scalp, abdomen, hands, and feet are mainly affected. Everything. The itching is worse at night, and she's finding it difficult to sleep. Which condition fits with the clinical scenario? Which condition is that, my friend? This is the famous intrahepatic cholestasis. Yes, well done. Okay, well done, my friends. In the preconception, what is the lower limit of the preprandial target range of plasma glucose in a woman with type 1 diabetes? Which plasma glucose level is most appropriate? In the pre-pregnancy phase, we advise the woman with diabetes who are planning to become pregnant to aim for the same capillary plasma glucose target range as recommended for all people with type 1 diabetes. Fasting plasma glucose level of 5 to 7 on waking, and plasma glucose level of 4 to 7 before meals at other times of the day. So if he asks you before meals, preprandial, so choose 4 to 7, right? Okay. So it should be starting from 4, not less than 4, of course. Right? Right. If asking about fasting, what you will choose? Five. Before meals is 4. Okay? And we can have a quick revision of the numbers. Please take care. The numbers and level of control of diabetes, again, very easy, and you can simply mess the question, right? Focus when he asks you fasting on waking up okay? Or before meal. Focus when he asks you before pregnancy or after pregnancy, control before or after, okay? Also, they ask about the control of diabetes during labor, during the time of delivery, okay? So be careful, my friends, okay? Quick look to the number. Target plasma glucose and HbA1c level before pregnancy, okay? The woman with type 1 diabetes planning a pregnancy to aim for normal capillary plasma glucose target range, fasting level of 5 to 7 on waking, plasma glucose level of 4 to 7 before meals at all other time of the day. Advise the woman with diabetes that planning pregnancy to aim to keep their hemoglobin A1c below 48 millimole per mole, or if by percentage is 6.5. Okay, my friends, we advise them not to get pregnant. We advise them not to get pregnant if the hemoglobin A1c is 86 millimole per mole, 10%, not to get pregnant, okay? Yes, well done, okay? Okay, so how about the control during pregnancy, okay? The control during pregnancy is different or not? There is no different. What do you think? The target blood glucose level during pregnancy is for a diabetic woman, okay, that she should have fasting 5.3 and 1 hour after meal 7.8, 2 hours after meal 6.4, okay? They ask also about the diagnosis of GTT, okay? For a woman who had gestational diabetes, when to say that this woman is diabetic after the result of the glucose tolerance test. You diagnose diabetes if the woman had either fasting plasma glucose level of 5.6 or above, 2 hours plasma glucose level 7.8 or above. Okay, my friends, very important numbers, okay, for your exam. How about during labor? Is there any recommendation for the during delivery? First of all, you should avoid hypoglycemia. Hyperglycemia also is harmful, okay? So both are avoided. So what is the better control during labor? 4 to 7, okay? Blood glucose during labor and birth, it should be maintained between 4 to 7. And yes, you measure it every hour. Okay, okay, dear friends. Okay, so this was a nice guideline, okay, on the management of diabetes, and the most important point, okay, in the measurement of the diabetes or the control of diabetic level comes, as I told you, preconception, antenatal, during labor, okay? They ask you these questions. They even sometimes ask you about the postnatal follow-up. So I advise you today, guys, after we just finish our meeting, that you go for the diabetes guideline and revise the most important numbers of it. Timing of delivery as well is advised, and the mode of delivery, when to advise for delivery for a woman with diabetes type 1 with complication or without a complication, diabetes type 2 with complication or without complication, okay? Because it comes in the exam, okay, more frequently nowadays. Okay, my friends who are asking about the time, okay, we have only a few questions to go. So, in a 38-year-old woman referred to antenatal clinic by the community midwife, she is previously fit and well. She is 32 weeks in gestation in her first pregnancy. She had consistent blood pressure reading of 155/105. Apart from headache, she had no symptoms. There is no proteinuria. What is the most appropriate management from the list? We had a similar question to that. Again, it's the oral labetalol, right? It should be. Yes. 3 weeks after forceps delivery, where an episiotomy performed, a woman present with fever, lethargy, recurrent labial abscesses. Okay, so guys, take care here, okay, because this is the key word to answer. Okay, the woman developed small abscesses, okay, in the labia. It's recurrent. These have not responded to oral fluoxetine or coamoxiclav, so means that we have a resistant strain, okay, of the bacteria. So what is the most likely pathogen? Okay, I'll ask you, my friends, and you tell me, please, okay? Shall I choose the Staph aureus or shall I choose Streptococcus? Which one cause the recurrent labial abscesses? From the guideline, Green Top guideline number 64, bacterial sepsis following pregnancy, recurrent abscess formation, including labial abscesses, is a feature of the PVL producing staphylococci. Okay, my friend? So this is the key word here. It's PVL staphylococci. Okay? We will have another infection, and you can compare between both infection, my dear. Okay? When the answer is Streptococcus pyogenes. Okay? I'll show you this one in a minute. Staphylococci. The PVL producing staphylococci because of the recurrent abscesses. Okay, this question about a woman, 10 hours, okay? The other one was 3 weeks, okay? Here is 10 hours. After delivery by cesarean section, an obese woman with type 2 diabetes complained of pharyngitis. She is commenced on coamoxiclav but deteriorate rapidly. So which infection can appear 10 hours after delivery, started with pharyngitis, deteriorate rapidly, with high fever, breathlessness, and tachycardia? Serum lactate level is elevated to 4.3. Oh my God, this is sepsis. So what is this infection? This is the Streptococcus pyogenes, right? Early presentation of sepsis, less than 12 hours post-birth, is most likely to be streptococcal infection, particularly the gas infection, okay? Okay, my friends, so the different presentation. Yes, I agree that the gas is the most common cause of maternal sepsis, but still you can have a question like the question number 40 that we discussed, okay? And the answer is not gas, it's staphylococci because of the characteristic description that he gives you. Okay, so let's have a question on a woman, 34 weeks of gestation, attend the antenatal assessment unit with symptoms suggestive of preterm, pre-labor rupture of membrane. A speculum examination is performed which show pooling of liquor in the vagina. Identify the most appropriate treatment. She is 34 and we have pooling of liquor in the vagina. What shall I do now? Antibiotic. So erythromycin 250 4 times per day. This is the most important one at that moment, right? Can I consider steroid for this case? Okay, so if I have both of them in the exam, antibiotic with P-prom or steroid, and I need to choose between one of them, which one I will go for? You will go first for now. No. It's a P-prom case. And it's 34 weeks, okay? And the antibiotic is mandatory, but I can consider the steroid. So in the exam, if I have both of them, I would go for the antibiotic. If I have a preterm labor in a patient below 30 weeks, preterm, not P-prom, and I have both steroids and, for example, tocolysis, which one to go for first? Okay, so it's according to the gestational age. Okay, thank you, my friend, for your information. Okay, Dr. Maya, I can send you a video, okay, from the author of the guidelines, says follow the NICE guideline, okay, for the recommendation of preterm labor. Thank you. Okay. Haemophilus influenza. Is what? Which type of vaccine? They nowadays ask questions about the types of vaccine and if it is safe in pregnancy or not. Conjugated vaccine. Is it safe during pregnancy? It's a polysaccharide conjugated vaccine, which is a type of inactivated bacterial vaccine. HBV is subunit. Can I offer it to a pregnant woman with sickle cell disease, for example? It's a conjugated vaccine. It's called the polysaccharide conjugated. Okay. A woman present with asymmetrical eruption of the erythematous papule. A. The previous question is A. So eruption of the erythematous papule that evolve into concentric rings of varying color with central pallor. Which condition fit with the clinical scenario? This is happen with the, yes, exactly, with the skin reaction that can be triggered by infection or some medication, right? It can be mild or it can be severe in rare cases. So it's called erythema multiforme. It's erythema multiforme, my friend. Symmetrical eruption of erythematous papules that evolve into a concentric ring of varying color with central pallor. It's allergic reaction. Okay? Erythema multiforme. Yes, we have solved this one. A slim, low-risk woman is delivering in a standalone midwife unit, and she had betadine for pain, and now she had a shoulder dystocia and has not resolved it by the McRoberts position and suprapubic pressure. What is the most appropriate option now? Why did he write slim? Episiotomy, my friends, is not done to relieve shoulder dystocia. It's only done when you do a maneuver to facilitate the maneuver, okay? But the problem of the shoulder dystocia, it's a bony problem. It's stuck, you know? So it's a truck stuck under bridge, right? So it's a bony problem. It will not be solved by the episiotomy alone. So episiotomy is not one of the maneuvers to relieve or to treat the shoulder dystocia, but it will be done to facilitate other maneuvers, okay? That's it, okay? But he wrote here that the patient is slim and she is a low risk and she is in the midwifery unit. So choose an option with less intervention because she is in a standalone midwifery unit. And because there is a line in the guideline that says, okay, for a slim, mobile woman without epidural and with a single midwifery attempt, all 4 position is probably more appropriate, right? And clearly, this is maybe a useful option in a community setting. For less mobile woman with epidural anesthesia in place, internal maneuvers are more appropriate. So this is what came in the guideline. So the person who wrote the guideline, who wrote the question, he just, you know, he made a design, okay? He just tailored the question to the same lines in the guideline. And he gave you slim as a keyword, right? He give you midwifery unit, and it's a standalone, not even inside the hospital. So this is one thing. Another thing, he confirmed that the patient is mobile. She only received the betadine, not epidural. Okay. The diagram did not include. That's why there is a guideline, right? Okay, my friend. No, in the diagram, my friend, of the shoulder dystocia, because it's a protocol, it's something that we all unit have to follow, okay? There was 2 arms comes and 1 arm going to the posterior shoulder delivery and 1 arm going to the all 4 position, right? Right? And for the specific scenario of this case, only all four position is appropriate. You think that a midwife will do episiotomy and internal maneuver with a woman in a standalone midwifery unit? I'll tell you another one, okay? My friends, if a woman had a cord prolapse and she's in a hospital, will you manage differently if this woman in the midwifery unit, in the standalone? Yes. So remember, in the cord prolapse and in the shoulder dystocia, the place of the delivery makes different. Okay? Clear? Answer is A for my friends who are asking about what answer. It's all four position. Yes, guys, we should have some actions in the exam, okay? So it's not all just, recall of common question. It's sometimes they want to know if you have, a deep knowledge of the guidelines or not. So which maneuver for shoulder dystocia is associated with neonatal humeral fracture rate of 2 to 12? Yes, it's delivery of the posterior arm. Yes, here answer is D, delivery of the posterior arm. A woman with chronic hypertension who took enalapril preconceptionally with a switch to methyl dopa, is that the one? Okay. Sorry. The repeated one. Okay, so let's solve another question. In a shoulder dystocia, which maneuver should be performed first? McRoberts, right? Yes, it's McRoberts. Well done. So what type of delivery may result in a small increased risk of an adverse outcome in a low risk nulliparous woman with cephalic presentation at term? So what is the most appropriate place or type of delivery? Yes, this is the home birth. Yes. So my dear friends, I was happy actually to have you today. Okay. And I think we have finished almost one paper of the management of labor, complication, obstetric. It was like a general obstetric questions. And I was so happy by your performance as well. You are doing really well, my friends, and take care of yourself, okay? And trust yourself and your abilities before your exam. You are on the right track, okay? So today, what you need to do by yourself, okay? Try to test your knowledge, please, okay? So this is what you will do, dear friends. Tomorrow, we are going to continue, okay? But usually, it will be a questions or a revision of the postnatal module. Okay, thank you very much for your time and see you tomorrow, inshallah. Thank you.